Welcome to our lecture on cardiopulmonary lab values. As a physical therapist, you will not be ordering lab tests, but you absolutely need to know how to read them. These values tell you whether it is safe to mobilize a patient, how aggressively you can progress their exercise, and when you need to hold therapy altogether. Let's get started. As shown on the screen, lab values affect three areas of your clinical decision-making. Oxygen capacity tells you the ceiling for cardiovascular workload. Clotting risk determines your approach to manual therapy and fall precautions. Metabolic state tells you about cellular energy and whether exercise is safe at all. Every lab category we cover in this lecture ties back to one of these three questions. We will start with respiratory values, since assessing oxygen status is the first thing you do with a cardiopulmonary patient. SpO2, which you will measure frequently with pulse oximetry, has a normal range of 95 to 100%. Below 90% indicates hypoxemia and possible respiratory failure. PaO2 measures oxygen dissolved in arterial blood. Normal is 75 to 100 millimeters of mercury. Below 75 suggests hypoxemia and lung disease. PaCO2 reflects how well the lungs are clearing carbon dioxide. Normal is 35 to 45 millimeters of mercury. Above 45 indicates respiratory acidosis, meaning the patient is retaining CO2. Below 35 indicates respiratory alkalosis, meaning the patient is blowing off too much CO2. Normal blood pH is 7.35 to 7.45. Below 7.35 is acidosis, and above 7.45 is alkalosis. Bicarbonate, or HCO3, has a normal range of 22 to 26 millimoles per liter. Low bicarbonate suggests metabolic acidosis. High bicarbonate suggests metabolic alkalosis. We discuss these in more detail along with respiratory and metabolic acidosis and alkalosis in the ABG lecture video. Now that we have covered oxygen in the lungs, let's talk about how it gets carried in the blood. Hemoglobin and hematocrit tell you about oxygen delivery to the tissues. When these are low, less oxygen is reaching the muscles, which increases cardiac workload and limits exercise tolerance. Normal hemoglobin is 13.5 to 17.5 grams per deciliter for males and 12 to 16 for females. Normal hematocrit is 40 to 52% for males and 37 to 47% for females. Low hemoglobin or hematocrit indicates anemia. High hematocrit, called polycythemia, increases blood viscosity and is common in COPD patients responding to chronic low oxygen levels. Now that we've got that down, let's go over the appropriate interventions for patients at different hemoglobin thresholds. Above 12 grams per deciliter, normal activity progression is appropriate. Between 10 and 12, keep exercise low intensity with light resistance and ambulation. Between 8 and 10, exercise capacity is markedly reduced. Limit the patient to essential ADLs, light weights of 1 to 2 pounds, and avoid aerobic activity. Below 8, no exercise. Many facilities use this as the cutoff for getting out of bed. Hematocrit has similar thresholds. Below 24% means no exercise and only essential ADLs with assistance. Between 24 and 30%, light activity and essential ADLs only. Note that post-cardiac surgery patients commonly present with decreased hemoglobin and hematocrit. Expect them to be more symptomatic during activity and monitor vital signs closely. Now let's move on to white blood cell and platelet count. White blood cells reflect the immune system. Normal range is 4,000 to 11,000 cells per microliter. Below 4,000 is leukopenia, meaning the patient is immunosuppressed and at increased infection risk. Consider precautions in your treatment setting. Above 11,000 is leukocytosis, indicating active bacterial infection or inflammation. Platelets control clotting. Normal range is 150,000 to 450,000 cells per microliter. Below 150,000 is thrombocytopenia with increased bleeding risk. Above 450,000 is thrombocytosis with increased clotting risk. As shown on the screen, platelet count directly determines what exercise is safe. Below 10,000, no activity at all. There is high risk of spontaneous hemorrhage with minimal trauma. Between 10,000 and 20,000, light active range of motion, walking, and ADLs only. No resistance. Between 20,000 and 50,000, you can add light resistance, walking, and stationary bike. Above 50,000, minimal to moderate resistance exercise is allowed. Moving on to cardiac biomarkers, when cardiac muscle cells are damaged, they release specific proteins into the bloodstream. The two we need to know are troponin and CKMB. Troponin is the gold standard. It is found exclusively in cardiac muscle, making it highly specific. Normal troponin I is 0 to 0.1 nanograms per milliliter, and normal troponin T is 0 to 0.2. Any elevation means myocardial damage has occurred, and higher levels suggest greater damage. Troponin rises 3 to 6 hours after injury, peaks at 12 to 24 hours, and stays elevated for 4 to 14 days. CKMB is a secondary marker. Normal is less than 3% of total CPK. Greater than 6% strongly suggests MI. The limitation is that CKMB can be falsely elevated from skeletal muscle injury, including after orthopedic surgery, so troponin is more reliable for confirming cardiac damage. Now that we've covered how to identify cardiac damage through biomarkers, let's talk about INR. This measures how effectively the blood is thinned, particularly in patients taking anticoagulants. Normal INR for someone not on anticoagulation is about 1.0. The therapeutic range for most patients on warfarin is 2.0 to 3.0. Below 2.0, the blood is too thick and clotting risk increases. This is especially dangerous in patients with atrial fibrillation. Above 3.0, the blood is too thin and spontaneous bleeding risk goes up. Above 5.0, many facilities will hold PT entirely. For any patient on anticoagulation, fall prevention is your top priority. Always check your facility's specific policies regarding INR thresholds for mobility. Now, let's move on to electrolytes. Electrolytes are essential for cardiac conduction, muscle contraction, and nerve transmission. There are 4 to pay attention to. Potassium is the most important for PT. Normal is 3.5 to 5.0 milliequivalents per liter. Low potassium causes muscle weakness and life-threatening arrhythmias, including PVCs and VTAC. High potassium affects cardiac contractility and can lead to cardiac arrest. If potassium is below 3.0 or above 6.0, do not exercise the patient. Sodium normal is 135 to 145 milliequivalents per liter. Low sodium causes confusion, weakness, and seizures. High sodium typically indicates dehydration. Chloride normal is 98 to 106 milliequivalents per liter. Chloride generally follows sodium, so when sodium is abnormal, expect chloride to be as well. Calcium normal is 9 to 11 milligrams per deciliter. Low calcium prolongs the QT interval and can cause muscle cramps and tetany. High calcium shortens the QT interval. Note that patients on loop diuretics for heart failure are at high risk for potassium and sodium losses. Monitor for sudden muscle weakness or new arrhythmias during your session. Electrolyte imbalances often point back to the kidneys. 2 renal markers to know are creatinine, with a normal of 0.6 to 1.2 milligrams per deciliter, and BUN, with a normal of 7 to 20. Creatinine is the more reliable of the two. When both are elevated, the kidneys are not filtering effectively. These patients will have fluid retention and electrolyte problems that directly limit exercise tolerance. This is especially common in heart failure. Shifting from electrolytes to metabolic values, many of your cardiac patients will also have diabetes, so you should be aware of glucose parameters. Normal fasting glucose is 70 to 100 milligrams per deciliter. Below 70 is hypoglycemia. The patient may present with shakiness, sweating, confusion, and weakness. Stop exercise immediately and give a fast-acting carbohydrate like juice or glucose tablets. Above 100 fasting suggests prediabetes or diabetes. Hemoglobin. A1C measures average blood glucose over the past 90 days, which makes it a better indicator of long-term glucose control than a single reading. Normal is below 5.7%. Between 5.7 and 6.4% is prediabetes. Above 6.5% is diabetes. The goal for diabetic patients is below 7%. For exercise in diabetic patients, 100 to 250 milligrams per deciliter is generally safe. Below 100, the patient may need a snack before starting. Above 250 with ketones present, or above 300 regardless, do not exercise. There is significant risk of diabetic ketoacidosis. Staying with metabolic values, let's look at blood lipids. Elevated blood lipids are a major risk factor for coronary artery disease. HDL is the good cholesterol. Higher is better, with optimal above 40 milligrams per deciliter for males and above 50 for females. LDL is the bad cholesterol, with optimal below 100. Total cholesterol should be below 200, and triglycerides below 150. The total cholesterol to HDL ratio is actually more predictive than any single lipid value. A patient with total cholesterol of 180 sounds fine, but if their HDL is only 30, that ratio is 6.0, which is poor. Compare that to a patient with total cholesterol of 240 but HDL of 80, giving a ratio of 3.0, which is good. Now, let's move outside the cardiovascular panel and cover a few hormonal values you will see in patient charts. TSH is your primary thyroid marker, with a normal range of 0.4 to 4.0 micro-international units per milliliter. High TSH means hypothyroidism, and the patient may present with fatigue, weight gain, and low resting heart rate. Low TSH means hyperthyroidism, with increased metabolic rate and elevated resting heart rate. T4 and T3 are the hormones produced by the thyroid gland. T4 is converted into T3, which is the form that regulates metabolism, heart rate, and body temperature. T4 normal is 4.5 to 12.5 micrograms per deciliter, and T3 normal is 80 to 200 nanograms per deciliter. Two other hormonal values to be aware of. Estrogen normal is 30 to 400 picograms per milliliter. Below 30 is associated with osteoporosis and premenopausal symptoms. Above 400 increases the risk of stroke, blood clots, and inflammation. Testosterone in men has a normal range of 300 to 1,000 nanograms per deciliter. Below 300 is associated with decreased muscle mass. Above 1,000 may cause irritability and aggressiveness. The last two lab values we have left to discuss are ESR and CRP. ESR, or erythrocyte sedimentation rate, is an inflammatory marker. Normal is less than 15 millimeters per hour for males and less than 20 for females. Elevated ESR is common in autoimmune conditions like rheumatoid arthritis, lupus, and osteomyelitis. High sensitivity CRP should be less than 1.0 milligrams per liter. When it is chronically elevated, cardiovascular risk increases regardless of other factors. The last category to cover before we wrap up is blood typing. There are four main blood types: A, B, AB, and O. Type O negative is the universal donor because it has no antigens to trigger an immune response. Type AB positive is the universal recipient because it has no antibodies to attack donor blood. You can see the full compatibility chart on the screen. Before we finish this lecture, take a screenshot of this slide. These are the values where you hold therapy and consult the medical team immediately. Troponin above 0.1, hemoglobin below 8, platelets below 10,000, potassium below 3.0 or above 6.0, glucose above 300, and INR above 5.0. When in doubt, hold therapy and consult. For more videos like this, visit typicalpt.com. The full course covers every topic on the NPTE to help you pass the first time. Thanks for watching, and we'll see you in the next one.